everyone. I hope you're all doing well. My name is Rashika, and I'm the chairperson of SUPTA. Welcome to today's session on breast surgery. We're very excited to have you all here with us today. Uh, Today, I am joined by Mo, who will guide breast surgery. Just to introduce Mo, he is a fourth year from the University of Sheffield. To make the session as engaging as possible, we'll be releasing polls throughout the session, so be sure to participate. These responses are completely anonymous, so we encourage you to participate actively. If you have any questions during the session, please feel free to pop them in the chat and we'll be happy to address them towards the end of the session. We'll also share a feedback form at the complete this your attendance, along with exclusive discount codes to teach surgery and pass the MRCS. This session and the recording and slides will be shared on a Metal page as well as the website a couple hours after the session. So follow that. As you all hopefully know by now, we have launched our very own learning portal, which is hosted on our website. Through this learning portal, you'll access practice questions, session recordings, and revision material. As a bonus, all members will get a discount code to get 10% off the Geeky Medics Anatomy flashcards, surgical flashcards, and the Knowledge Bundle. Membership is completely free, so be sure to head on to our website after the session to explore this. We also have an exciting opportunity for all of our attendees. Two people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the Google form at the end of the session and enter the unique code we will provide. The more sessions you attend, the higher chances of winning. So be sure to stay until the end of today's session and attend as many of our other sessions until the end of the series. Finally, before we begin, we'd like to thank our partners, the Royal College of Surgeons England, Geeky Medics, the MDU, More Than Skin Deep, Medal, TJ, and Pass the MRCS. Without further ado, I'll now hand it over to Mo.
Hi everyone, my name's Mo. I'm a fourth year medical student at the University of Sheffield. I've got a really good, big passion for surgery, and today I'm going to be teaching you about breast pathology. We're going to be going over some of the benign and the malignant conditions. Breast cancer is really common. It's the most common cancer in women, and it's really highly relevant. If you're sitting in GP, a lot of patients will come in with breast issues, and it's a really common referral as well. So we'll go through, thank you to all our partners as well for helping us set up these sessions. And I'll take you through the learning objectives. So what we're going to go through today is understanding the anatomy of the breast and the breast examination. Understanding the anatomy is really useful to help you understand some of the conditions we talk about later on. And within the breast examination, I'll teach you how to distinguish between a benign and a malignant condition, which is really useful. So we're going to go over some of the benign breast conditions, such as fibroadenomas, cysts, and metastases. And I'll also take you through the process of breast cancer screening and the diagnosis and treatment of breast cancer. Perfect. So we'll start with the anatomy. I'm sure most of you have seen images like this. It demonstrates on the right side here the thoracic wall and the pectoralis major, with the breast itself being in front of the pectoralis major. You've got the lobules, which we'll talk about, the lactiferous ducts, which also are just referred to as ducts, and then the fatty tissue, which is the breast tissue itself. Going into some of these, so the structure of the breast is composed of glandular tissue, connective tissue, which holds everything together, and the adipose tissue, which is the fatty tissue we talked about. The glandular tissue itself is composed of the lobules and the ducts. So the lobules are on here, the purpley bits. They produce the milk, and then this milk then drains through the ducts and converges at the nipple, which the milk is then released from. The blood supply is mainly from the internal thoracic, lateral thoracic, and intercostal arteries. Now, this is important, but I've put a little star next to the lymphatic drainage because this is really important, as this is how cancer can spread. So we'll talk about it later on, but cancer can spread through the axilla and onto other parts of the body as well. So it's really important to know that it's the lymphatic drainage is through the axillary nodes, but also the supraclavicular and the internal mammary nodes as well. So it's important to check these. The nerve supply is the intercostal nerves, which provide sensory and autonomic innervation as well. Perfect. So we'll go on to the examination itself. Before you start, there's general principles. Most of them are the same as normal examinations for any other conditions, but I'll go over a few points just to highlight. The first thing is you want to explain the reason and the process for the examination, because patients will be coming in and they'll be really stressed. So if you take a minute to just explain what you're going to do, it can really help them be at ease. You obviously want to obtain informed consent. Having a chaperone present is really important. Allow the patient to get undressed and dressed in privacy. You really want to remain their dignity, and make sure that they're covered up until the point of examination. You don't want them to just be unnecessarily exposed. Obviously, ask about any areas of pain, any abnormalities that they've noticed themselves. So this can be really important because they might be self-examining at home and they've realized something that is a new change, which is more of a suspicious indication. And then also, if you have a minute, you can teach them how to self-examine as well, because this is really important. We've got the next steps here as well. We'll go through them together. So when it comes to inspection, there's three different positions, that you want to examine the patient in before you even start feeling and palpating. The first one is relaxed with your arms by your sides. So this is just the neutral position. Then you're going to want them to put their hands on their hips and press into it. What this does is it contracts the breast and the pectoral muscles to check for any tethering, which is just the skin or nipple being pulled inwards or fixed. And this could indicate a malignancy, so it's really important. And it's the same with when the hands are placed behind the head. The key things you're going to want to comment on. So this is if you're the consultant or registrar you're with asks you to look at a breast, you want to comment on any asymmetry. Could be size or shape. Now, these can be normal, but it's important to note this down because in their next appointment, you can compare between the two. Any scars or cosmetic augmentation. So this is implants or other cancer surgeries. This is important to note down as well. We've spoken about the tethering or fixation of the skin, and then any nipple changes as well. These can also be normal, but it's important to document it down, and also any discharge, because some forms of discharge can be really red flags. So we need to focus on these. Finally, we've got skin abnormalities. Erythema is just a reddish inflammation. Peau d'orange, we'll speak about that later on, but it looks like a very dimply, like an orange peel, and it signifies a blocked lymphatic drainage. You've also got Paget's disease of the nipple. This looks like eczema on the nipple, and we'll talk about that again later on. Perfect. So when it comes to palpation, this is right after the inspection. It's important to use the flats of your fingers. If you're using the fingertips, what you can do is the surface area is decreased and you might miss some lumps. It's also hard to get the depth right. So make sure you're using the flats of your fingers. You need to position the patient in lying back 45 degrees with their hands behind their head. Only one hand behind their head, which is the side that you're being examined on. You've got 4 different methods for examination. I'll go through them all. So we've got the vertical lines. This is going up and down, usually starting from the outside of the breast all the way towards the sternum. This is the most thorough, it's the most evidence-based, and it reduces missed areas. Then we've got the quadrants. This is splitting the breast into 4 different quadrants. You've got the upper outer, upper inner, lower outer, and lower inner as well. So these 4 quadrants are really important, and it's useful because when you're documenting it down, there might be usually they have a picture of a breast in 4 different quadrants, and you note down where any lumps are. So if you've examined in that way, it's easier to remember and note down. You've then got the spiral method, which begins at the nipple and you move outwards in concentric circles. This ensures that you cover all the tissue layers and you make sure that you've assessed the nipple as well. The last one, you've got the radial/wedge examination, and for this you want to picture a clock face, and starting at the nipple and moving outwards, you want to cover every number on the clock face. This helps precisely locate abnormalities, so you could write on the patient notes a lump found on 2 o'clock position. What I would recommend is try out all 4 of these different methods and then pick the one that suits yourself. You might want to use 2 as well, so you might use the vertical lines or the quadrants, and then if there's an area that you're a bit suspicious about, you might use the clock face pattern. So it's really useful. Now, if you do get stuck during an examination, the main thing to remember is that you've got 3 areas to cover: the 4 quadrants of each breast, the subareolar area, which is right underneath the nipple, and we'll come on to this later, but there are some conditions that can present with a lump there, so it's really important to make sure you don't feel anything suspicious there. Then you've got the axilla and the tail of Spence. The axilla is just the armpit. You want to feel all borders of it, anterior, posterior, lateral, and medial. And then you want to move on to the tail of Spence, which is just the bit in between your breast as an extension to the axilla. Perfect. We'll move on from that. Now we're going to talk about, if you do find a lump, what you're meant to do. To help you distinguish between the two, benign lumps are usually small, smooth, mobile, and non-tender, so they're not painful. Whereas malignant lumps are usually hard, irregular, and fixed. So if you were feeding back to a consultant the details about a breast lump, you want to mention all of these if you can: the location of it, the size of it, the shape, whether it's round, oval, irregular, its consistency, which is soft, firm, hard, or fluctuant, and then the margins as well. So if it's an irregular margin or if it's smooth. We've spoken about it being mobile or fixed. So if it's fixed, that's when you see the tethering sign on inspection. Then you've got tenderness, which may indicate an abscess. And then skin color, you've got erythema, which we've spoken about as well, which is inflammation of the breast tissue. And then some nipple discharge can indicate different conditions, which we'll move on to later on. Perfect. Okay, so these are some further steps that you want to do after you've done the breast examination. So you want to examine for any lymphadenopathy, examine cervical and supraclavicular lymphadenopathy. It's important to note that if they have supraclavicular lymphadenopathy, which is new, this is a poor prognostic sign. Then you want to ask about any metastases symptoms. So the 4 most common areas for metastases in breast tissue is liver, lungs, bones, brain. And this is important to remember. It could come up in an OSCE question. I've seen it before. So just try and remember those 4. And the sort of questions you can ask is, do you have any bone pain, any new cough, breathlessness, or any neurological symptoms that they're dealing with? And then finally, you want to do the triple assessment. This is really important, and we're going to focus on this quite a lot because this is the mainstay diagnosis for any malignant breast condition. So it includes the clinical assessment, which is history and examination, and then it moves on to imaging and histology. We'll focus on that now when we come on to breast cancer. So breast cancer, as we've said, is really common. It's the most common cancer in women. So we really want to focus on this quite a bit. There is a screening in the NHS. It's from women aged 50 to 70 They're invited every 3 years. If you are high risk, for example, you have the BRCA gene or the P53 gene, or you have a really strong family history, they might start earlier with MRIs or mammograms. You could even be starting from the age of 30. Yep. And then if you're over the age of 70, it's important to note that you won't be regularly invited every 3 years, but you can self-refer for a screening. Perfect. Now we'll move on to referrals. This is important for anything you decide to go into the future. If you're a GP, you'll see loads of patients coming in with breast lumps, and it's important to distinguish what it is and also what type of referral you need to give them. So if anyone over the age of 30 presents with an unexplained breast lump or with or without any pain, you want a 2-week wait referral. And that's the same if anyone over the age of 50 presents with unilateral nipple changes. This can be discharge, retraction, or anything that's concerning them. You also want to consider this for any skin changes suggestive of breast cancer, or anyone over the age of 30 with an unexplained axillary breast lump. If they are under the age of 30 and they present with a breast lump, you can refer them for a non-urgent referral, which is typically 4 to 6 weeks, I think. Okay, so we mentioned the triple assessment. We're going to go over this, and you'll see it again later on. The first thing to do is a clinical examination, and where you'll take a history of a patient, you'll do the inspection and palpation of both breasts and the axilla. Then in the same clinic, it's called a one-stop clinic, they'll be sent for imaging. If they're under the age of 40, an ultrasound is better because their breasts will be more dense. But if they're over the age of 40, they will have a mammogram and maybe an ultrasound as well if there's something suspicious. There's 2 types of tissue sampling. The first one is a fine needle aspiration. This just gives you cytology, and it's quite quick, but it's quite limited as well. So the more preferred option is a core biopsy. Most doctors use this now, and it provides histology and can give you a definitive diagnosis. Perfect. Now we're going to go on to some of the types and classifications. So if you remember before in the anatomy, there are lobes and there are ducts. The lobes produce milk and the ducts converge at the nipple. So this is how we classify breast cancers as well. We have ductal carcinomas in situ. This is when the cancer is confined into the duct. Then we have invasive ductal carcinoma, which is the most common presentation of cancer, of breast cancer. And this is when DCIS usually spreads beyond the ducts, and it's also recently been named as non-specific type breast cancer. So if you see this in any exam questions or in practice, that's invasive ductal carcinoma. Next, we have lobular carcinoma in situ, which is confined to the lobes. And then invasive lobular carcinoma, which is much less common, and it's often multifocal and bilateral, but this is an invasive form when it's broken out of the lobes. 2 of these we looked at briefly before is Paget's disease of the nipple, which is, it kind of presents like eczema in the nipple, which is why if you ever have a patient coming in with eczema on the nipple that's not reacting to steroids, they need to be seen urgently in the 2-week wait referral. We also have inflammatory breast cancer. This presents similar to mastitis, which is a breast infection. It presents with red, swollen, peau d'orange skin, which we spoke about before, which is the orange peel dimpling. And it's due to lymphatic drainage. So it's kind of like a breast edema, and it signifies, it can indicate inflammatory breast cancer. So if you see a patient coming in with mastitis that's not reacting to antibiotics, the main differential diagnosis you want to rule out is inflammatory breast cancer. And it's really important to do so. Perfect. Now we'll move on to the breast cancer receptors. We've got three main ones here to focus on. You've got estrogen receptor positive. This is when cancer cells grow in response to estrogen. Progesterone receptor positive. This is when cancer cells grow in response to progesterone. And then finally, we've got HER2 positive, which is an overexpression of the HER2 protein, which accelerates tumor growth. These three are really important. You'll see they're always checked for because they dictate what sort of treatment you'll give. And yeah, we'll look into these a bit more later. Perfect. Now, the surgical management can be quite complicated and it's not often taught very well. So the way I like to think about it is there's two presentations that you can get when it comes to breast cancer. And this dictates what sort of surgeries they'll need. So if they come to you in clinic and they have an absence of axillary lymphadenopathy, so they've got no swelling in their lymph nodes, and this is during the triple assessment in the one-stop clinic, the first thing you do is you want to do the primary tumor surgery. So this is the either breast conserving therapy, like a wide local excision, or a mastectomy. Now, there are different indications for either one, and I've got a slide on that, so we'll go through that. But so the main thing is remove the tumor from the breast tissue. Then we want to focus on axillary surgery. With this, so they've presented with no lymph node swellings. You're going to do a sentinel lymph node biopsy. And what this is it's taking the first 1 to 3, usually 1 to 3 lymph nodes coming out of the breast tissue that are in the axilla. And this helps you dictate what sort of management they'll be doing after. So if you take the first 1 to 3 lymph nodes coming out of the breast, and it's negative, that you won't need any further axillary surgery and they'll be declared node negative. So that's the best outcome. If you do the sentinel lymph node biopsy and it's positive, you're going to need further management based on the node involvement. So if it's only 1 to 2 positive nodes, you might want to do radiotherapy to save them from, if there's more than 3 nodes, you would do an axillary lymph node dissection. And what the sentinel lymph node biopsy actually does is it reduces the amount of people that need to go in for axillary lymph node dissection, because historically all the patients that came in with breast cancer would have their axillary lymph nodes dissected, which is quite invasive. So the sentinel lymph node biopsy reduces the number needed if they're negative or they only have 1 to 2 positive nodes. The next presentation, is if during the triple assessment they present with axillary lymphadenopathy, so they have at least 1 swollen lymph node. What you would do after that point is, this is after the examination and the imaging, you would then do typically a core biopsy, ultrasound guided. If this is negative, you would do the same as before and you would do a sentinel lymph node biopsy. If it's positive, the patient is now node positive. And so you would do the primary tumor surgery, either breast conserving therapy or mastectomy. And then the next step is doing the axillary surgery, same as before. If it's got more than 3, typically you would remove the axillary lymph nodes and do a dissection. If it's 1 to 2 nodes, you could alternatively do an axillary radiotherapy. Perfect. So we'll go on to some of the complications now. As we said, axillary surgery can be really invasive. So it's important to learn how to identify some of the complications of this. So the main one is chronic lymphedema, and this is due to a disruption of the lymphatic drainage after axillary node dissection. It typically presents with arm swelling, heaviness, and increased infection risk. And the management is limb elevation, compression therapy, and physiotherapy. So the common exam scenario would be a patient's coming to you 6 to 12 months after their breast surgery that had node involvement, and they've come in and they've had arm swelling, they're struggling to move their shoulders, they've got increased infections. The main thing you want to be thinking about, the main differential, would be chronic lymphedema. And the management, as we've said, limb elevation, compression therapy, physiotherapy. This is a really big issue and it's very controversial, so they like to ask it in exams. Some of the other complications, nerve injury, which also is very heavily exam focused. So I've got the next slide is on that as well. You've got shoulder stiffness, which is not being able to move it around too much. Seroma formation. Seroma formation is basically all the vessels in your breast are going to be cut during surgery. So a lot of serous fluids will fill the breast. Usually it resolves by itself, but sometimes if there's a lot of pressure, you might need to drain it as well. And obviously the last thing is with all surgeries, there's an infection risk. So keep an eye on this as well. So when it comes to nerve damage and nerve complications in breast surgery, it can be quite complicated because they're all very similar. But I've put them in a table for you. Try and memorize this for your exams because, as I've said, it's really high yield. They really like examining it. So I'll go through them now with you. We've got the long thoracic nerve, which innervates the serratus anterior. This can be damaged during axillary node clearance. So this is the dissection we talked about of the axillary nodes. And the clinical consequence is winged scapula. So when you put your hands on a wall and push, one of your scapulas will protrude backwards, and also difficulty elevating the arm above the head. Then we've got the thoracodorsal nerve. This innervates the latissimus dorsi. It might be injured during axillary dissection. The clinical consequences of this are weak arm adduction, extension, and internal rotation. This might affect shoulder movement and function. It's usually subtle, but important to pick up on. We've got then the medial and lateral pectoral nerves. These innervate the pectoralis major and minor. They may be injured during a mastectomy or implant placed under the muscle. So usually implants are placed in front of the pectoralis major, but sometimes they're placed under. So if it is, watch out for these nerves. It leads to weakness in shoulder adduction and internal rotation, muscle atrophy or asymmetry, which then can obviously lead to cosmetic deformity. Next, we've got axillary nerve. This innervates the deltoid and teres minor. It's quite rare, but can be injured in a deep dissection near the axillar apex, or if the retractors are placed quite aggressively. What this leads to is weakness in shoulder adduction, especially from after the 15 degrees up to 90 degrees, and also a loss in sensation of the lateral deltoid. So there'll be, like they call it, regimental badge. So there'll be an area on your shoulder where you just have no sensation. Perfect. Sorry, I know these are really boring and mundane to learn, but I can't stress enough how important these are for exams. So just try and commit this table to memory. Nice. So we'll move on to what I mentioned before, the primary tumor surgery, which is the first surgery you do, which is just removing the breast tumor from the breast. There's two different techniques you can use: the mastectomy, which is removing the whole breast, or a wide local excision, which is using a small margin to go around the whole breast tumor, but leaving the rest of the breast intact. And you can have reconstruction after the wide local excision. So the reasons why you might want to do a mastectomy, if it's a multifocal tumor, quite central, if it's large in a small breast, and if it's a DCIS with that's greater than 4 centimeters. When it comes to wide local excision, if it's a solitary lesion, peripheral tumor, small lesion in a large breast, or the DCIS is less than 4 centimeters. But ultimately, it comes down to patient choice. If you think that a wide local excision will be suitable, but the patient doesn't really want to go for the risk and prefers to remove the whole breast tissue, if the patient's allowed to decide, as long as you think it's safe as well. Moving on to adjuvant therapy, what this means is this is the treatment that we give patients after the primary surgery, and this reduces the likelihood for recurrence. So we've got a few different things, and if you remember, we spoke about the breast receptors, the breast cancer receptors. This is what determines this treatment. So initially, we've got radiotherapy, which is used after a wide local excision, or a mastectomy, or axillary surgery. And yeah, we use it for high risk recurrence, and it can drastically reduce the risk. We've then got chemotherapy, and this is for high risk or node positive cancers. It can also be given neoadjuvantly. What this means is if we're scheduling a patient for a breast cancer surgery in 6 weeks' time, they might have a 4-week course of chemotherapy beforehand. And what this does is it shrinks the tumor beforehand to make the surgery easier. And it can also reduce the number or completely eliminate the number of positive lymph nodes in the axilla. So they might not need to have axillary surgery afterwards. We've also got hormonal therapy. This is really commonly assessed in exams as well. So if they're ER positive, they'll have hormonal therapy for about 5 to 10 years after the breast surgery. If they're premenopausal, it would be tamoxifen. If they are postmenopausal, it would be an aromatase inhibitor such as letrozole. Lastly, we've got biological therapy. This is for the HER2 positive cancers. Now these ones grow really aggressively, but it's good that they react very well to trastuzumab, which is also known as Herceptin. Remember that one, and then you can also remember pertuzumab, which is used in conjunction with trastuzumab for anything that's high risk. Finally, we've got the staging systems. There are obviously loads of staging systems, but I've got the 3 main ones here that I think are important to focus on. We've got the Nottingham Prognostic Index, otherwise known as the NPI. This is used to predict prognosis based on tumor size, lymph node status, and histological grade. I've got the formula here for you. I've never seen it being asked in an exam. I really doubt they'd ask you to do the calculation from memory. If they were to ask you, they would give you the formula and expect you to know how to use it. It's also important to take into account that a high NPI score indicates a worse prognosis. Moving on to triple assessment notation. So triple assessment is the thing we spoke about a lot. It's examination first with the history, then imaging, and then a biopsy if needed. So this helps you categorize the breast cancer as benign, suspicious, or malignant. Lastly, we've got TNM staging system. This is the tumor, which is the size and extent of the primary tumor. So you get certain points for how large the tumor is. The nodes, so this is how many lymph nodes there are in outside of the breast that are in like the axilla usually. And then we've just got the presence or absence of distant metastases. So I think you get a certain amount of points for presence and certain for absence as well. Perfect. So that sums up breast cancer. I know it's a lot to take in, but as I said, it's really important and quite topical. So make sure to go over it. The notes on the PowerPoint are nicely summarized, so you should be able to memorize some of the tables, for example. Okay, we'll move on to breast lumps. It's really important to note that most lumps in young women are going to be benign, but if you're unsure, you should still refer because there's a lot of overlap clinically between a breast lump that's benign and malignant. And I know, for example, some breast consultants who have 30 years experience who sometimes feel a lump and think it's benign, and then it turns out to be malignant. So if you're unsure, please refer, and the triple assessment will decide if it's malignant or benign. Also, if you're worried about the triple assessment being too invasive, they won't do a biopsy unless there's something shown on imaging. So typically, most of the time, it's just examination and imaging, which is good. Perfect. We'll start off with fibroadenoma. So a fibroadenoma is a benign breast lump, most commonly found in a younger woman under the age of 30, and it's typically referred to as the breast mouse because it's painless, mobile, well-defined breast lump. It's like a really small breast lump that most women don't even realize is there, and it moves around their breast all the time. The diagnosis for this is the triple assessment, as we've previously mentioned, and the management is, if it's asymptomatic, you can just reassure, and it's not too big, and it's not bothering the patient. Reassurance is okay. If there's a rapid growth, or it's greater than 3 centimeters in size, or if the patient really just doesn't like it and wants it taken out, we can excise it. Cyclical myalgia. This is breast pain linked to the menstrual cycle. So how this presents is usually bilateral pain that's not localized anywhere, and it's just a general pain in both breasts that's worse right before their periods. The diagnosis for this is just clinical. You can take a history and an exam and diagnose it. And the management, really important lifestyle changes here. Wearing a supportive bra can really help, and reducing caffeine is shown to really benefit these patients. You've also got NSAIDs, and last line is hormonal therapy if it's really severe. And we'll go on to fibrocystic changes now. So this is the most common cause of cyclical myalgia. It's common in premenopausal women as well because it's hormonal related. And the presentation is lumpy, tender breasts that are usually worse before menstruation. And when I say lumpy, I don't mean 1 or 2 lumps. I mean lumps all around both breasts. And they can improve post-menopause, but usually they come back if the patient started on HRT. The diagnosis for this is, again, very similar to cyclical myalgia. It's clinical exam and an ultrasound or mammogram if needed. And then the management is mainly the same as before: reassurance, wearing a supportive bra, and NSAIDs if really painful. Perfect. We'll go into intraductal papilloma now. So this is another benign tumor of the breast ducts. So remember, the lobes produce the milk and they're deeper in the breast, and then the ducts they converge at the nipple and let the milk pass out through the nipple. So it's a benign tumor here, and the presentation is usually premenopausal women. The discharge from the nipple would usually be bloody or clear, and this is the most common symptom. They might have also a small subareolar lump, but often it's not palpable. But this is so in the examination before, when I said a really important point to examine is right below the nipple. This is why, because there's a couple conditions that can present with lumps here, and you don't want to miss them. In the exam, if you see bloody nipple discharge, this is probably the most likely cause, especially if they're young as well. So top differential this. The diagnosis is a triple assessment, and for this, the management is surgical excision because there can be atypical cells inside the benign tumor. So you want to rule out malignancy. Also important to do regular follow-ups if there's more than one or any high-risk features present. Moving on to mammary duct ectasia. So I always think that intraductal papilloma and mammary duct ectasia are really similar. They both are benign conditions affecting the milk ducts. However, this isn't a tumor growth. It's when they become dilated and inflamed. So the presentation is usually perimenopausal women, and instead of a bloody or clear nipple discharge, this one is non-bloody. It's green/yellow nipple discharge. It can also present with nipple retraction or nipple tenderness, and a possible lump right underneath the nipple. The diagnosis for this is, again, the triple assessment. So you want to do clinical exam, checking for nipple changes or discharge, ultrasound and mammogram to exclude malignancy, and then you can biopsy if it's suspicious, like if they have bloody discharge or irregular mass. The management for this, you don't need to surgically remove this, but you can if the symptoms persist or if there's an infection that develops. But usually you just want to reassure the patient if it's asymptomatic, and then maybe do a warm compress and NSAIDs if it's really discomforting. Moving on to mastitis. Now, I don't think mastitis is usually taught that well. I like to look at it as mastitis is like an infection in the breast. And the most important thing is to separate it into two subtypes. There's lactational and non-lactational. Now, again, this is really high yield for exams. So the lactational one is infection due to milk stasis. So this is when a woman who's breastfeeding has milk that's clogged up one of the ducts and then it becomes infected. Then you've got non-lactational, which is often inflammatory, seen in smokers or diabetics. And it's important to look out for this as well. The presentation is breast pain, redness, swelling, and a fever if it's infective. But yeah, it's just a generally inflamed breast. And in the exam, if you suspect mastitis, they will either be breastfeeding and it will be lactational, or there will be a smoker typically, which means it's non-lactational. That's the key differential, I would say. The diagnosis is usually clinical, history and examination, and you can do an ultrasound if you feel a really tender area that with a cyst formation, you might want to check for an abscess on ultrasound. The management is to continue breastfeeding if it's lactational, and to give antibiotics, flucloxacillin usually, and drain if an abscess forms. It's important to note, if it's lactational, start the antibiotics and keep breastfeeding. The question will usually be, what is the management plan? And it will say continue breastfeeding and give antibiotics, or just give antibiotics and stop breastfeeding. You need to continue breastfeeding so that you can remove the plug in the duct. Okay, the last one is Phyllodes tumor. This isn't really that common. It's a rare fibroepithelial breast tumor. And what fibroepithelial means is it contains stromal tissue, which is just the connective tissue we talked about, and also epithelial tissue, which is the ducts and the lobes. It can be benign, borderline, or malignant. It's more common in middle-aged women, and the presentation is similar to a fibroadenoma, but it's painless, fast-growing breast lump, which is well-defined, smooth, and mobile, but it obviously is bigger and it grows more rapidly. The diagnosis for this is a triple assessment, and the management is usually a wide local excision or mastectomy. You need to remove this because it has the ability to become malignant. Okay, perfect. So I think we're going to move on to the poll questions now. I think, Rashita, if you could make sure they're active.
Yep. So I've just released the
Perfect.
first poll question.
Perfect. So I'll read out the questions and then I'll give you guys a minute or so to give me an answer, and then we'll go through it together. So a 32-year-old woman presents to her GP with a painless, firm lump in her right breast that she noticed 2 weeks ago. She has no nipple discharge, skin changes, or axillary lymphadenopathy. She has no significant family history of breast cancer. What is the most appropriate next step in management? You've got A, which is an urgent 2-week wait referral, B, which is non-urgent referral, C, which is a routine mammogram, and D, which is reassure and review in 6 weeks. So I'll give you guys a minute to have a look at that.
So we've gotten 20% going with A, 60% going with B, and 20% going with D.
Okay, that sounds good. I'll give you a few more seconds and we'll check the answer. So most of you are correct. It's option. Actually, I think most of you have gone for B. What we need to look out for here is because she's over the age of 30 with an unexplained breast lump, they need to be seen in urgent 2-week wait referral. So for the non-urgent referrals, this would be if the patient was under the age of 30. And because she's over the age of 30, she needs to be seen in the next 2 weeks. Option C is a routine mammogram. So this is only done in screening when they come in and just have a mammogram. If anyone is symptomatic or they've come from their GP, they need to have a full triple assessment, which is the examination and history, then imaging, then a biopsy. Option D is reassure and review in 6 weeks. This is delaying the assessment unnecessarily, and with the purpose of breast cancer screening and examinations is to get an early detection because this really improves outcomes. So we need to get this seen in 2 weeks. Okay, perfect. We'll go on to the next question. So a 55-year-old postmenopausal woman is diagnosed with a 3-centimeter node positive, ER positive, HER2 negative, invasive ductal carcinoma. She undergoes breast conservation surgery. Which combination of adjuvant therapies is most appropriate? Okay, so I'll give you guys another minute to go over that. I'll read out the options as well. We've got A, which is radiotherapy and tamoxifen, B, which is chemotherapy and aromatase inhibitor, C, which is biological therapy and chemotherapy, and D, which is radiotherapy and biological therapy.
We've got 100% going with B.
Okay, perfect. So you guys have smashed that. It's the correct answer is B, and this is because the cancer is ER positive. So you either want to use an aromatase inhibitor or tamoxifen, and because she's postmenopausal, this limits you to using an aromatase inhibitor, such as letrozole. The chemotherapy is also used because the patient is node positive, and it, as we said, it reduces the risk of recurrence of the cancer. Radiotherapy is not usually used after a mastectomy unless there are high-risk features such as a lot of positive nodes or involvement of the chest wall. And then biological therapy, which is the trastuzumab, is usually used for HER2 positive cancers, which this one is ER positive, not HER2 positive. Nice. We'll go on to question 3 now. A 62-year-old woman undergoes a mastectomy with axillary lymph node dissection for node-positive breast cancer. 6 months later, she presents with progressive swelling and heaviness in her right arm. Given the most likely diagnosis, how should it be managed? So we've got A, which is anticoagulation, B, which is limb elevation and compression, C, which is IV antibiotics and surgical drainage, and then D, we've got urgent vascular review. I'll give you guys another minute.
We've got 100% going with B.
100% B. Really good. You guys have smashed it again. The answer is B. And the reason for this is because she's got chronic lymphedema. There are other differentials as well, but because it's progressive swelling, that usually indicates chronic lymphedema, which is also the most common complication of axillary lymph node dissection. Other things I had in mind was a DVT, which you'd need anticoagulation for. Cellulitis, it could be, which you'd do IV antibiotics and surgical drainage. And then potentially an axillary vein thrombosis, which need urgent vascular review. Nice, you guys are doing well. Question 4, which is a 52-year-old woman presents with 2.5 ER positive, HER2 negative, invasive ductal carcinoma. She has no palpable axillary lymphadenopathy. An ultrasound of the axilla is normal. She undergoes sentinel lymph node biopsy, which reveals 4 positive lymph nodes. What is the appropriate next step in axillary management? So we've got A, which is no further axillary treatment. B, which is repeating sentinel lymph node biopsy to confirm findings. C, which is axillary radiotherapy alone. And then D, which is axillary lymph node dissection.
We've got 100% going with D.
Okay, very good. That's the correct answer again. Correct answer is D, axillary lymph node dissection, and this is because there are more than 3 positive lymph nodes in the sentinel lymph node biopsy. So we obviously have to do a full dissection, removing all the lymph nodes so that we don't get a reoccurrence or any further metastases. Radiotherapy alone is probably used when there's less than 3. I'd say 1 or 2. That should probably be less than 3, not less than and equal to 1 or 2. And then no further axillary treatment is incorrect because there's significant nodal burden, which means there's lymph nodes that are positive in the axilla. So you need to do something. And then repeating the sentinel lymph node biopsy won't do anything as well, because the initial biopsy is already confirmed that there's nodes involved in the axilla. Nice. So question number 5. A 30-year-old smoker presents with a painful erythematous lump near the nipple. There is associated nipple retraction, but no discharge. Examination shows an area of induration, and ultrasound suggests an inflamed duct. Which is the best initial treatment? A, urgent wide local excision. B, radiotherapy. C, antibiotics and smoking cessation advice. And D, hormonal therapy. Give you guys another minute to look at that.
We've got 100% going with C.
Perfect. So it seems you guys were paying attention during the presentation. C is the correct answer. What we've got here is periductal mastitis. So this is the non-lactational mastitis. Correct answer is antibiotics and smoking cessation advice. So periductal mastitis typically affects smokers. You need to give the antibiotics to stop the acute presentation, and then smoking cessation advice will help with the acute and also long term as well. The wide local excision is only for chronic cases with abscess formation. So if you have someone that's coming in repeatedly, you might want to surgically remove the duct itself, which can really help. And then radiotherapy and hormonal therapy, they're not used for this condition. Last one, we've got question 6. So a 55-year-old woman presents with nipple discharge that is greenish and thick. She also reports mild breast discomfort, but no palpable lump. On examination, there is nipple retraction, but no erythema or axillary lymphadenopathy. What is the most likely diagnosis? We've got A, which is mammary duct ectasia, B, which is ductal carcinoma in situ, C, intraductal papilloma, and D, which is breast abscess. So it's the last question.
We're 100% going with A.
Perfect. The right answer again. You guys are doing great. So the correct answer A, mammary duct ectasia. It's a benign condition causing nipple discharge, often green, yellow. So that's perfect. When you see nipple discharge, it's typically going to be green or yellow. This is for the benign conditions, green, yellow, which is mammary duct ectasia, and then bloody or clear, which is intraductal papilloma. Keep that like sort of mind map in your head. You also get nipple retraction and ductal dilation. A DCIS may present with bloody discharge as well, but they would see microcalcifications on imaging. An intraductal papilloma, this is bloody discharge, and then breast abscess presents with erythema, pain, and fever, and just inflammation all over the breast. So that's all for today. Thank you very much. I've released also another, I think it's 15 or 20 breast questions. They're a bit more difficult than these ones here. These ones to give you a bit more confidence, but the other 20 might be a bit more difficult. But don't worry. And also, I think Rashita is going to let you guys know about the feedback, which I would really appreciate. It helps me with my application and to improve my next presentations. But yeah, thank you very much.
Thank you, Mo. That was really good. That was very helpful. I'm sure it was helpful for all of your revision. I have released the feedback form in the chat. So don't forget to fill it out. As Mo said, you will be able to receive your certificates and also discount codes for teaching surgery and pass the MRCS if you complete this feedback form. I have also sent a Google form for a chance to win free access to the Geeky Medic surgical flashcards and their OSCE stations. The link for this again is available in the chat. Our next session is going to cover neurosurgery, which is going to be on April 14th at 7 p.m. We'd love for you to join us again, so be sure to follow us on our social media platforms, and the links for this again is available in our chat. Through this, you will be able to receive updates on the upcoming sessions via these platforms. We've also posted additional SPAs that Mo has very kindly created for us. This is available on learning platforms, so definitely check that out. We hope you found today's session helpful and engaging. If anyone does have any questions, please do feel free to put them in the chat, and I'm sure Mo will be more than happy to answer them for you. But if anyone doesn't have any questions, thank you so much for joining us again, and we look forward to seeing you all at our next session next month and next Monday. Thank you, everyone.
Thanks, guys.